Good evening and welcome to all of my dear friends. I hope everyone is staying happy and healthy, and I'm pretty sure you have been revising all your topics, not just medicine, all the subjects very well and in a very precise manner. So only few days are left for the day to be celebrated, for which you have been preparing from lot of months, and in fact you can say for the day which you have been dreamed about. See, I always say exams are like festival. So on the day of examination, you need not to worry. You need to dress well. You should be happy. You should be charming, and you should be in a very jolly mood. Yes, prior to the exam, that is the time when you have to put all your efforts. You have to prepare very well, and you have to maximize your energy to gain the knowledge which you have achieved in the course of MBBS and during the preparation time, right? So, guys, before we start today's discussion, so today's discussion is going to be for the particular FMG students, and we have given the name FMG Mission 150, right? I always say don't aim only for 150, rather, you should aim for at least 250 or more than that, so that you may achieve nearby some 200, 225, 240 marks, right? Okay, so before we start today's session, I would like to request everyone to please tell me about the audio video thing, and is everything okay? I am waiting for your on the chat box. Good evening, Mohan. Good evening, Hemant. Good evening, Dr. Khan. Good evening, Bulan Saab. Hemant, good evening. Mohammed, good evening. Shadab, good evening. Okay, so we can start about the discussion. Okay, so before we discuss today's topic, let me remind you the exact way how to approach an MCQ. Guys, always read the last line, what they are asking, most appropriate treatment, what is the next step of management, or whatsoever they are asking, that is the important. Then go for the options, then read the story based MCQ. While doing this thing, or by doing this thing, what you will achieve, that your subconscious mind will immediately start answering or bombarding in your brain towards a right option, right? So again, you will have 1 minute, total 1 minute to read and answer that, and then after 1 minute I will read and we will start discussing about that question. Okay, so here we start with the very first question. Yes, guys, you have 1 minute time. Yes, guys, so 1 minute is over. Let's read what is the last line they are asking. What is the most appropriate initial management? Right. So they are asking about the management, and options we do have is a drop-in, observation, DC cardioversion, permanent pacing. Now, when we read these options, a drop-in, observation, DC cardioversion, or permanent pacing, our mind is taking us towards that this patient is having some bradycardia, or maybe this patient is going to in some arrest, right? Means he is having a low heart rate. Why? Because you see atropine is given when the patient is having bradycardia, or patient may be in some kind of heart block, cardioversion. Obviously when there is a problem with the rhythm, permanent pacing, obviously when there is a problem with the rhythm. Now let's read the question carefully. A 60-year-old male patient who is admitted in CCU after an inferior wall MI. Now, point to be remembered over here, guys, that we have discussed earlier in when we had a detailed class about the about the cardiology. What we have learnt over here, that this inferior wall MI, what is the complication of inferior wall MI? Yes, we know the complication is bradycardia. So we are very clear about this thing, that the complication is bradycardia. Now, my dear friend, underwent percutaneous intervention, you notice a heart rate of 45 per minute. As I told you, the complication of inferior wall MI is bradycardia. Point to be remembered over here. BP is 120 to 56. He is comfortable otherwise and mobilizing around his bed. ECG is suggestive of complete heart block. What is the appropriate initial management? So you people are giving me the answer as A, atropine heart rate less than 60, healthy med talk C, future doctor D. So majority of you people are giving me the answer as an A and as an permanent pacing. Guys, read this question carefully once again. Why you want to go for a permanent pacing over here? Why you want to go for a permanent pacing over here? Read the question carefully. What I am saying is this, right? That what I am saying over here, that look at the question carefully, there is a clue over here. The patient is completely fit and fine over here because he is comfortable otherwise. Just a second, guys. He is comfortable otherwise and mobilizing around his bed. Yes. So guys, when the patient is comfortable and mobilizing around the bed and he is having an adequate hemodynamic, only just for heart rate, you still can wait and watch. What you can do? Wait and watch, right? Because I told you that the complication of inferior wall MI is what beta is always bradycardia, right? Bradycardia. One thing, complication of inferior wall MI, right? And it occurs due to the ischemic changes, and it occurs due to the damage of the AV node, damage at the AV node. This bradycardia is occurring because of the damage of the AV node. In these patients, my dear friend, do remember this thing. If you find that this patient gets unstable, if this patient gets unstable, only then you have to go for DC cardioversion, or you have to go for permanent pacing. But over here you can see that this patient is having a blood pressure of how much, beta? How much is the blood pressure? How much is the blood pressure over here? The blood pressure is 122 and 56. So it means patient, hemodynamically patient is stable. Yes, I do agree, because of AV nodal block, the patient has landed up into complete heart block, for which you can still wait and watch. Patient is conscious, patient is having a good blood pressure, right? So guys, over here the answer is going to be this answer is going to be a right answer. We have to go for an observation as of now. Yes, after 45 minutes or 1 hour, or if the patient is having a decline in the GCS, or decline in the hemodynamic, HD I'm writing hemodynamics, right? Obviously then you have to act quickly and you will start with atropine. And if the blood pressure drops, you can go for cardioversion. And if the heart rate goes below 40 and the patient gets symptomatic, below 40, patient gets symptomatic. Symptomatic means, symptomatic, what I mean to say is, right, what I mean to say by symptomatic means the patient is getting drowsy, patient is getting drowsy, or patient is having palpitation, patient is having chest discomfort, right? Patient is having syncope, These all are called as symptomatic patients. Yes, in these patients you have to go for cardiac pacing. CP means cardiac pacing. As of now, you can wait and watch, right? So the answer was B. Yes, Dr. Jahid, Vasita, you have given me the right answer. So really appreciate your answers. Let's go to the next question. You have 1 minute time to answer the question. Okay, so it's a very simple answer. Cardiac pacing is indicated in which of the following? So options we have is reversible sinus bradycardia, carotid sinus syncope, patient with a history of syncope and documented asymptomatic pause of 3 seconds or more, asymptomatic Mobitz 1 heart block. Right. So guys, I think this is a very simple question. They have just asked about the indication. So over here, the answer is going to be the B. Carotid sinus syncope is going to be the answer. So let's quickly discuss about the indications of cardiac pacing. So what we are going to discuss is about indications of cardiac pacing. So indications of cardiac pacing. I'm just quickly going to revise the indications of cardiac pacing, and I'm pretty sure you all of you know the indications. First of all, the patient is symptomatic. As I just told you in the question number 1, the patient should have a symptomatic heart blocks, symptomatic heart block. HV is, it can be even a Mobert's type 1 heart block, right? So don't go for Mobert's type 2 or complete heart block. Any patient who is having symptomatic, just now we have discussed about the symptoms, they are the indications for heart block, right? Second, my dear friend, patient with a history of syncope, history of syncope, right? And patient should have a documented, do underline this thing, documented asymptomatic, asymptomatic pause of more than 6 seconds, right? More than 6 seconds. Now here in the question it was 3 seconds or more. So answer is basically more than 6 seconds. It is not 3 seconds. So you have to do remember this thing. It is 6 seconds, right? Then my dear friend, other indication is third degree, third degree or Mobitz type 2 heart block also. This is an indication, right? Okay. Then fourth, as I told you, it is carotid sinus syncope. Carotid sinus syncope is an indication, right? Then another indication is, fifth indication is, if patient is having left ventricular failure, if the patient is having what beta, if the patient is having left ventricular failure with ejection fraction of less than 35%, with ejection fraction of less than 35%, and patient should be symptomatic, and the patient should be symptomatic. So these are some of the quick review of the indications where you have to go for a cardiac pacing, right? So do remember this, guys. Okay, ji. Can we move to the further question? I hope we are very clear with this question. Okay. Again, you have 1 minute time. Time's up, guys. Time's up. Let's read the question now. They are asking to identify the underlying cause. Which among the following investigation is best suitable? So options we have is cardiac biomarkers, echocardiography, Holter monitoring, and CT head. These are the options. Now let's read the question. A 60-year-old male visits your clinic with history of collapse. Very important. With history of collapse and history of loss of consciousness for 5 to 10 seconds. Very important. How much seconds? 5 to 10 seconds, which resolves spontaneously. That is another history which resolves but beta spontaneously. He had 3 episodes of collapse in the past 1 year with no warning sign. The important history. But beta, this is the important history. There are no warning signs. Family members deny any history of, another very important history of, any other history of seizure, but reports that he is a non-case of hypertension for which he is taking bendroflumetazide on examination. Heart rate is okay, 76. Blood pressure is also okay, right? Blood pressure is also okay, and saturation is 98%, right? To identify the underlying cause, which among the following investigation is best suitable? Hanji guys. So you are giving me the answer like D. Majority of you people are giving me the answer D. So let's have a discussion upon city head. No, city head is not the answer over here. No, city head is not the answer over here. So I am taking out this city head. Now I can explain you why the city head is not the answer over here. First of all, read the question very carefully. From the question, it looks like the nature of collapse, or better I would say the origin of collapse, is not neurological. It is more of cardiac origin, right? Why it is more of cardiac origin? Because see, if the patient had a nature of neurological origin of collapse, then the patient would have gone for a prolonged unconsciousness. Prolonged unconsciousness. Let's suppose you are suspecting the nearest, which is TIA, transient ischemic attack. At least with the transient ischemic attack, we know this. What is transient ischemic attack? If the neurological symptoms or the deficit resolves within or less than 24 hours. So it means at least they remain for some hours over here, right? Whereas in our question, what is happening? In how much seconds it is recovering? It is recovering in 5 to 10 seconds. And if the origin is neurological, let's say the patient had some event over here, or a TIA, or even stroke over here, the patient would have fallen, patient would have some kind of facial injury, some kind of facial bruise over there, right? Or maybe patient would have developed SDH or SAH, maybe, I'm just saying. So there is no history of some neurological symptoms. Some more, if you read the question carefully, what you can find over here, that there is no history of any denial history of any seizure, and he is just a non-case of hypertension. Let's say the patient had a stroke. Just presume that, according to you guys, that you are presuming that CT head needs to be done. Where is the neurological deficit by? Where is the neurological deficit? There is no neurological deficit. So do remember this thing. Now, so it looks like that this is of a cardiac origin. Maybe the patient has gone into heart blocks. Maybe the patient is going into heart block, and due to heart block, the patient goes into syncope, right? The patient can go into syncope, right? And syncope is loss of consciousness for some seconds, and there is a spontaneous recovery. Do remember this thing. Now let's talk about the cardiac biomarkers. Is the cardiac biomarkers going to be the answer? No, the cardiac biomarkers are only responsible if there is a damage to the muscles. Let's say the patient had a myocardial infarction. Only that time we are going to check for the CPK-MB, troponin I or troponin T, right? Or if the patient had a left ventricular failure, we would have gone for pro-BNP. But as in the question, there is no indication that the patient had gone into any cardiac failure or any kind of myocardial infarction, because there is a spontaneous recovery. So the likely cause is the patient has gone into some kind of heart blocks. Now talking about the echocardiography. Echocardiography is going to tell us about the structure. Echocardiography is going to tell us about the structure and the function of the heart. And the function of heart, right? So we want to know about the rhythm problems, right? So yes guys, we are left with only one option. We can put this patient upon a Holter monitoring and this Holter monitoring will be done for 48 hours, and we can record the ECG of the patient, and we can study the rhythm problems of the patient, why this patient was going into syncope over here. That's why the patient is going to the answer is going to be a Holter monitoring for this option, right? I hope you have enjoyed this question, right? Anyone have given me answer? Yes, Komal, very good. I really appreciate your answer, beta. Yes, Deepak, you have given me the right answer. Baljinder, appreciate your answer, beta. Right, any more? Who people are giving me the answer? Hard blocks. Very good. I really appreciate your answers. Okay, Ji. Let's go to question next. I hope you all know the answer. This patient, okay. What is the most appropriate management option is propranolol, amlodipine, lifestyle modification, and methyl dopa. So let's read the question. So means all these drugs are given in a case of hypertension. We know this thing question now. The question is a 32-year female with a 26 weeks of pregnancy found to have BP 178/94. So it is a kind of severe hypertension, and protein in the urine are positive. So this patient is having proteinuria. So what is the diagnosis of this patient? The first of all, this patient is having severe preeclampsia. What is having? Severe preeclampsia. Right? So what do we see in severe preeclampsia? First of all, what do we see over here, my dost? We see that this patient will land up into hypertension, and generally this patient is having proteinuria. These patients have what, beta? Proteinuria, and there is always a risk of intrauterine growth retardation, or sometimes intrauterine death also if it is not controlled. But yes, the risk is always intrauterine growth retardation. Growth retardation. Intrauterine growth retardation. So what are the anti-hypertensive drugs which are used? The first line anti-hypertensive drug which is used is methyl dopa. So the answer is going to be the methyl dopa. Although methyl dopa helps us in treating the elevated blood pressure, this is going to be the first line drug. But yes, if methyl dopa, if you encounter that methyl dopa is not in the option when you are going to appear for your final exam, if methyl dopa is not in the option, then definitely, my dear friend, there will be a labetalol, and the other option we can have is nifedipine. These are the two drugs which can be used. Yeah, hydralazine can be used. I do agree with your point, right? Okay, so do remember this patient is having a preeclampsia. So guys, I request, you have done this in medicine and you have done this in gynecology, do revise the risk factors associated with preeclampsia. Also, I'm just quickly going to revise the risk factors associated with preeclampsia quickly, just a quick revision, right? Although you must have revised in gynecology. The first one is a positive family history. A positive family, this is an important topic. So a positive family history. Another history is primi gravidas, right? Then change of change in partner. This is also a risk factor. The fourth risk factor is prolonged interval between pregnancies. Between the pregnancies. Fifth is chronic hypertension. Chronic hypertension. Sixth is renal disease. Renal disease. Right? So then another risk factor, there is a teenage pregnancy also. Teenage pregnancy. This is also a risk factor. Right? Baljinder, in severe hypertension, labetalol is preferred. See, if it is not preeclampsia, if it is some other question, then yes, obviously labetalol will be the answer. Family history, yes, Mahik, CCB, labetalol, carbidopa, methyl-dopa, okay. Dipinder, you are asking best in between labetalol, nifedipine, methyl-dopa, if all three present in the option. See, all three are not going to be present in the option. If you have to, if somehow they put all these three options, this one, what do you call it as? Methyl dopa is going to be the answer. This is the first line, right? I have told you only if methyl dopa is not in the option, only then you are going to choose labetalol and nifedipine over here. Got my point? Okay, can we proceed to the next question? Very simple question. I am expecting the right answer from all of you now. So guys, time's up. Which of the following is most likely to be associated with severe left ventricular failure? Jerky pulse, pulses alternance, pulses bisference, collapsing pulse. Right, you have majority of you people is giving me the right answer. Yes, the answer is going to be pulses alternance. Yes, the answer is going to be the pulses alternance. Right. So just quickly revise about some of the important type of pulses and their association, I think. Right. So I'm just going to write a condition over here. I'm just going to write the condition over here. On the other hand, we will write about the what kind of pulse you are going to see. I'm just going to write what kind of pulse you are going to see. So let's say the patient is having, first of all, left ventricular failure, as we just discussed over here. So the patient is having left ventricular failure. In left ventricular failure, what kind of pulse you are going to see? You are going to see obviously pulses alternance, right? Let's say the patient is having tamponade. Let's say the patient is having tamponade. What kind of pulse you are going to see? You are going to see pulses just a second, guys. I don't know where it went off. Anyhow, we were talking about guys, just a second. I got some technical issue. Yeah, thank you. Is it okay now? You can see the full screen now. Is everything okay now? I'm just going to write over here. So pulses experience, where you are going to see over here, pulses experience, you are going to see in particularly mixed aortic valve diseases, right? Then my dear friend, where you are going to see this collapsing pulse, you are going to see this collapsing pulse in particularly aortic regurgitation, where you are going to see this pulses alternate in a case of left ventricular failure. Then my dear friend, you can see this pulses jerky pulse. Hanji, where can you can see this jerky pulse? Jerky pulse can be basically seen in HOCM. This jerky pulse can be seen in HOCM. Then, my dear friend, we do have another very important pulse that is called as pulsus paradoxus. Pulsus paradoxus. You can see this pulsus paradoxus in cardiac tamponade. Right? You can see this in cardiac tamponade in severe COPD or in severe asthma, right? They may ask you pulsus paradoxus. Do remember this thing. If there is a fall of systolic pressure more than how much beta? More than 10 millimeter of mercury in systolic blood pressure during deep inspiration. I repeat, during deep inspiration, if there is a fall of more than 10 millimeter of mercury in systolic blood pressure, then it is called as pulsus paradoxus, right? So these were the important point of pulses, right? Okay, let's proceed to the next question. Read this question carefully. Okay, time's up, guys. So the question they are asking is, what is the most likely cause? Hanji, what is the most likely cause over here? And the options we have is hemophilia A, hemophilia B, factor 7 deficiency, right? Then is antiphospholipid syndrome. So let's read the question. A 17-year-old male is brought to the emergency with large hemarthrosis. So guys, I have purposely framed this because I have seen this patient, and this young chap has actually presented to our hospital in emergency, right? That developed after he was playing a kabaddi match. Investigation: hemoglobin is 13 gram per deciliter, INR is normal over here, PT is 13 second, that is normal, APTT is increased over here. Do remember, APTT is increased over here. BT is 6 minutes, that is normal. Factor 8C is also normal. So what is the abnormality this patient is having? So what is the abnormality this patient is having, guys, over here? So this is the only abnormality this patient is having over here. So what is the abnormality? That this patient is having a higher, what you call it as APTT. Look over here. So this patient is having a higher APTT. So guys, you have given me the answer A, B, A, B, A, B. So I do appreciate your answer that you are thinking that this patient is hemophilia. Yes, it is hemophilia. Right. Now let's quickly distinguish between hemophilia A and hemophilia B. So let's quickly differentiate between hemophilia A and hemophilia B. So this is hemophilia A, and here it is hemophilia B. What we are going to take the points over here. So the first very important point what we are going to take is, we will write over here is, first of all we will talk about PT, then we are going to take about BT, then we will talk about APTT, right? And then finally we will talk about factor 8C activity. Now what happens over here, that in hemophilia what is happening over here, that this is going to be normal, right? Then this is going to be normal, right? This is going to be a high, APTT is going to be high, and this is going to be a low level thing, right? But now if we talk about this thing, this is going to be normal, this is going to be normal, this is going to be a high thing, right? And over here this is going to be a normal thing. So the what basic difference you have to think over here, that over here in hemophilia, do remember this thing, that the factor 8C level is going to be normal over here, whereas my dear friend in hemophilia A it is going to be on a lower side. That what it is written over here in the MCQ, if you read carefully, that the factor 8C is normal over here. And in which kind of hemophilia do you find normal? Over here in hemophilia B. Now what is hemophilia A? Basically there is a deficiency of factor, yes, can you please tell me what is the deficiency? Factor 8 deficiency. There is factor 8 deficiency. Factor 8 deficiency. So had it been a factor 8 deficiency, then the answer would have gone for hemophilia A, but it is normal, that's why the answer is going to be hemophilia B. Now in hemophilia B, which deficiency do we see? We see a factor 9 deficiency. So factor 9 deficiency is going to be there, right? I hope we have made this question very clear, right? Okay, so we can proceed to question number next now. Now it is visual, the first line is visual, I guess. Time's up, guys. Time's up. So let's read the question. What is the next most appropriate investigation they are talking about? So they are talking about what, beta? Investigation. So investigation, they include ABG, serum erythropoietin level, genetic screening for JAK2 mutation, and bone marrow aspiration. Now let's read the question. A 60-year-old plethoric male visits your clinic with complaints of pruritus. So here pruritus is very important from several last month. He explains that he feels uncomfortable, itching, burning sensation, especially while taking a bath. So he means he is taking uncomfortable, itching, burning sensation. Again he is explaining his pruritus over here. right? What is pruritus? An uncomfortable itching burning type of sensation over the skin, right? And which may aggravate while getting in contact with a hot water or in a hot weather also, right? So hot bath also, with taking bath with hot water. His past medical history is unremarkable. On examination, splenomegaly. Another important thing, lab reports. Now, you guys, this is a purely a hematology question, right? Read the lab reports carefully, and you will find there are some abnormalities over here, right? Majority of you is given me the right answer over here, right? So HV is 19. Is it is increased? Yes, it is increased. HV is on a higher side. So HV is going to be on a higher side. Hematocrit is on a higher side or not? Yes, hematocrit is also on a higher side. This is increased. WBC count 9.4. Normal range is 4 to 10,000. So it is normal. Platelet count is 304. Okay, platelet count is also normal. Neutrophils are increased. Neutrophils are increased over here. ESR is normal, right? CRP is normal, and creatinine is normal. So guys, can you please tell me what is the diagnosis? First of all, I would like to know what is the diagnosis of this patient. Muhammad, I really appreciate, Baljendra, I really appreciate your answer. You have given me the right answer. See, because hematocrit and hemoglobin both are increased over here, right? So what is the patient is suffering from? This patient is suffering from polycythemia vera. Polycythemia. It is basically polycythemia rubra vera. Both are included over here. PRV, polycythemia rubra vera. But anyhow, I do accept this your answer. Now, what is this polycythemia rubra vera? Basically, my dear friend, it is a disease of myeloproliferation. Myeloproliferative disorder. Myeloproliferative disorder. Do remember this thing, right? And it is best characterized by. Now, what are the important points? Do you have to remember in your mind that this is best characterized by an increase in hemoglobin and particularly cell mass. How this cell mass is going to be defined? By the level of HCT, by the level of hematocrit. Both hemoglobin and hematocrit is going to get increased. अगर मैं हिंदी में समझाऊं तो इसमें ब्लड गाढ़ा होना शुरू हो जाता है. Just a simple way to remember over there, right? And my dear friend, another characteristic feature is this, that this patient too come with pruritus, and the median age of this disease is approximately 60 years. Kitni hai age beta? 60 years. Yes, Sana Gautam, it is RBC count increases, hematocrit or RBC count, they increases, right? And these patients, they come with a burning sensation, right? Burning sensation over there. Okay, so guys, people who are giving me answer as erythropoietin level तो नहीं बेटा, ABG. Okay, ABG हम लोग तब करेंगे if the causes are apart from this thing, right? So can you please tell me what is the answer over here? Yes. So what we are going to do, we are going to do a genetic screening of JAK2 mutation, right? So what we are going to do, my dear friend, we are going to do the genetic screening of the JAK2 mutation, right? So ABG, why ABG is not the answer over here? To see if there are some secondary causes, if there are to rule out the secondary causes. So ABG is only done to rule out the secondary causes, right? Now, what are the secondary causes of this thing of polycythemia? It can be due to some, abnormal lungs, like in a case of COPD or an emphysema, right? Where the patient is having, hypoxemia, or let's say the patient is dealing with chronic hypoxia. There we can do the ABG. Okay. Beta, Mohammed, what is the management for policy? We have to go for this phlebotomy, right? You have to go for phlebotomy. Although you can add aspirin also, but phlebotomy will be the definitive choice of treatment or management. right? Okay, so let's go to question number next. I hope you have read this question now. Time's up, guys. What is the likely diagnosis? And the options is CLL, beta thalassemia major, myelofibrosis, myelodysplastic syndrome. Now let's read the question. A 75-year female complains of generalized weakness, lethargy, night sweats, and pain in abdomen from last 3 months. Her previous medical history is unremarkable. On examination, pallor is present. So this is an important thing, that pallor is present, right? Hepatomegaly and massive splenomegaly. So the patient is having hepatosplenomegaly. Now let's look in the lab reports. HP is on a lower side. Yes, we know this patient is anemic, and some more the pallor is also present. WBC is count. So this patient is having a higher WBC count. As I told you, the normal range is between 4K to 10K, 4,000 to 10,000, right? Platelet count is normal. The most important part over here is what, beta? The most important part over here is that blood film is telling us. What is this blood film telling us? It is telling us leukoerythroblastic film with teardrop poikilocytosis, right? Poikilocytosis. So now, guys, can you please tell me what is going to be the answer? So majority of you people is getting confused between these two options over here. Anyhow, I'm just going to tell you the right option. The right option is going to be the myelofibrosis. This patient is having the right answer is myelofibrosis. Now, why the myelofibrosis is going to be the answer over here? See, the history examination of this patient is suggestive of myelofibrosis. First of all, this myelofibrosis is what, beta? This is the myeloproliferative disorder, right? Which occurs by the clonal proliferation of what you call it as megakaryocytes, and that produce the platelet activated or platelet derived growth factors. We know this thing, right? Okay. The most common symptom of this myelofibrosis is lethargy. The most common symptom, right? Or rather, we can call it, this is the initial symptom. This is the initial symptom, right? And the patient may also go into a fever, prolonged fever. Patient may land up into weight loss, right? And night sweat, not net, and night sweat. These all are the initial symptoms. So the most common is lethargy, and lethargy is going to be the initial symptom also. Night sweat, weight loss, these all will be the symptoms. And the major clinical finding are going to be, you know, what, this splenomegaly and hepatomegaly, right? Why this occurs? Why hepatomegaly and splenomegaly occurs? It is very simple to understand, because there is an extramedullary hematopoiesis. So what is happening? There is extramedullary hematopoiesis, extramedullary hematopoiesis, hematopoiesis, right? Okay. Another important thing, okay, this thing, teardrop poikilocytosis, do remember this thing. This is because of the this basically reflects that there is extramedullary hematopoiesis is going on, and it is most commonly seen in myelofibrosis. Do remember this thing, right? Yes. Okay. Right. So this was the answer, myelofibrosis. So can we lead to the question number next? Okay, for this question, I have received only one right answer by Dr. Vasista Pahadi. Padi, right? Okay. Let's read the question. What is the most appropriate next step in the management? You people are giving me the next step in the management is IV filgrastim. Let me read the options carefully. Paracetamol, IV piperacillin, tazobactam, IV amphotericin, IV filgrastim. Sana Gautam, why you are giving me answer B? And this doctor, where they went off? Dr. Vasista Padi. Why you guys are giving me this one? Parth Prajapati, you are also giving answer B. Why? Whereas rest of you people are giving me the answer D. See guys, let's read the question carefully and let's see it is not so easy that you are thinking. A 25-year-old male who was recently diagnosed in AML and received his first cycle of chemotherapy 7 days back. Now is brought to emergency with complaints of several hours of fever and chills. Very important history, those several hours of fever and chills. He had no past medical history on examination. He is febrile. One thing, fever. Because of fever, yes, tachycardia is there. BP is okay. Pallor is there. Scattered purpura on his arm. His 7 days previous lab reports neutrophils are 15%. Very, very important, guys. This neutrophils are very, very important. Look at over here. This history of neutrophils are very, very important over here. What is the most appropriate next step in the management? Now, you people are saying that this patient neutrophils are there, right? I do agree that in neutropenia, chemotherapy induced neutropenia, you will give IV filgrastim. But do remember this thing, this patient is in severe neutropenic sepsis. So the diagnosis is what, beta? Severe neutropenic sepsis. Neutropenic sepsis is there, right? Now, why neutropenic sepsis is there? See, कितना है यहाँ पे fever? How much is the temperature? It is increased? Yes or no? Got my point? And there is chills. So active infection is going on, right? We know already the patient is immunocompromised because this patient is diagnosed with AML, right? And this patient is having a background of, let's say, acute myeloid leukemia, and this patient is have a significant bone marrow failure or a significant bone marrow depression is there, which will include the clinical anemia also, as the pallor is present over here. Now, if you read the sepsis carefully, the first thing you have to do is what? Take the blood sample and immediately inject or administer antibiotics empirically, right? Filgrastim, I agree, but now they are asking what is the next step in the most appropriate. So to come out of the, to make the patient to come out of this sepsis, you have to immediately administer the antibiotic over here. So IV piperacillin tazobactam is going to be the answer over here, right? Okay. People have given me answer C. Okay, answer C. Beta, antifungal normally administered in the patient with neutropenia after 48 hours if the patient is not responding to the standard treatment. Only then we give antifungals. When do we choose D? Beta, D option is only chosen if the patient, D can be given, but if the patient is not, why I have chosen the option B? Because the patient is in febrile state, the patient is in acute sepsis. Filgrastim can be given in, the patients where the patient is not febrile. Do remember this thing, right? But here the patient is having fever, chills history है, तो sepsis की history यहाँ पे आ रही है, इसलिए we are giving piperacillin tazobactam over here. And some more, if you read the sepsis guideline, they are saying once the patient has came to the hospital or under your treatment, within 1 hour you have to administer the antibiotic. Okay. So do remember this thing. If there is a history of again limelight, if you encounter, and high likely you are going to encounter this type of question, do read the question carefully. There is a history of fever, heart rate, everything is there. So you have to look for all these things. Okay, next question. Guys, another little tough question. I do accept this, that this is a little tricky question. Okay, still I am receiving the right answer. I really appreciate the people who's giving me the right answer. Okay, so let's read the question now. What is the best next step in the management? So they are asking olanzapine, reassurance, dexamethasone, metoclopramide. A 60-year-old female who is recently diagnosed as a CA bladder and received first cycle of chemotherapy 4 days earlier. Now presented with complaints of nausea and vomiting from past 2 days. We know the side effect of chemotherapy or the drugs which are given in for anti-cancer drugs. The most common side effect is nausea and vomiting, and this patient is having the same thing. But she is taking ondansetron since the start of chemotherapy. So already she is taking some anti-emetic, right? Like see, this is 5-HT3. What do you call it as antagonist? Antagonist commonly used, right? So this is ondansetron or granisetron, whatever you want to call, right? Ondansetron, granisetron, she is already taking, right? But didn't notice any relief in her symptoms. GI system examination is normal. What is the best next step in the management? People who think you are giving me the answer, bhai, reassurance is not going. So this is not going to be the answer over here. Reassurance. Why you want to reassure the patient? See, this is really a painful condition when the patient is having nausea and vomiting. Patient is not able to eat anything, and even these people look at the food and they start having phobia, and they start having nausea and vomiting. So reassurance is not going to be there. You have to act smart and you have to give some medication. Right. Now, do remember this thing. Particularly, this patient has received most likely CA bladder. Though most likely, I'm just presuming that this patient has received a cisplatin, right? Most commonly used drug. right? And approximately 90% of the patient who are receiving cisplatin, they undergo with this symptom of nausea and vomiting, right? And to have the prophylaxis of this nausea and vomiting, generally we doctors or the clinicians, they give ondansetron or ganacetron. But now, my dear friends, if the patient does not recover from this thing, there are several studies and trials which has given that dexamethasone, right? This dexamethasone is going to, along with this 5H3 antagonist, if you add steroids, then obviously the patient is going to have control over the symptoms over there, right? To be appear this steroids and 5H3 antagonist along with steroid, they have better effect and for the prophylaxis of GI symptoms like nausea and vomiting, right? Yeah, people, you are giving me metoclopramide is better. No, metoclopramide single is given. So what they are giving, I'm just going to add over here. What is the next step in the management? Read the question carefully. So adding the steroid is going to be a beneficial thing over here, right? So adding a steroid is going to be a beneficial thing for all of us, right? Okay, Ji. Very simple answer, I think. Most easiest answer. Yes, you gave me the right answer. So it is going to be a hypotension, which is the which among the following is less likely to be associated with steroid hypotension. Whereas hypertension is going to be the side effect over there, right? So just a quick, I'm just going to verbally talk about the side effect of the steroid. So the side effect of the steroid are like you can remember it from M M Cushing word. M Cushing word. Now, what is this M Cushing word, guys? M is acne, myopathy. Particularly, do remember it is going to be a proximal type of myopathy, right? Then this C is for Cushing word face. Or let's say the patient can have cataract. Patient can have cataract. U is for ulcers. S is for striae. H is hypertension, hypokalemia, hypokalemia, hair loss, or you can call it as an alopecia also, right? I is infections. N is necrosis, particularly that of avascular necrosis. I'm just writing in the bracket avascular necrosis, AVN, right? Then is glucosuria. O is obesity. Then I is immunosuppression. Immunosuppression. D is depression. D is depression. And some more from I, you can also remember insomnia. So these all are the side effect of the steroid. Most commonly asked question. Do remember they would love to ask you direct or indirect question upon hypokalemia and hypertension also. Right? Yeah, avascular necrosis बेटा लिखा ना ये दीपक ऊपर ये avascular necrosis. So this was the side effect of the steroids. Let's go to question number next. Guys, who is going to give me the right answer of this question? I would really appreciate that guy, and I'm going to send the person a gift, maybe chocolates, right? You have 45 seconds left, guys. Again, I'm waiting for 30 seconds, guys. Read the question carefully. Read it and Baljinder, read the ABG once again. Baljinder K. Sahi, sir, please read the ABG once again. Yes, it is alkalosis, but what kind of alkalosis is it? Okay, now let's read the question. Time's up, guys. They are asking what is the next most appropriate step in the management? Intubation, IV normal saline, activated charcoal, hemodialysis. So let's read the question. A 30-year-old male patient is brought to emergency with nausea, vomiting, and tinnitus after ingesting unknown tablets. So one thing is very clear that this patient has gone into some kind of poisoning, right? Although all this nausea, vomiting, tinnitus, these all they have consumed. The patient has consumed something, some substance or a tablet, and now he is suffering from all these symptoms, right? His family member reports that he smokes approximately 15 to 20 cigarettes per day. On examination, how much is the GCS beta? 10 out of 15. 10 out of 15. Do remember, this is very, very important thing. 10 out of 15. Temperature is 100.6. Heart rate is 98. Blood pressure is 122. 78. Respiratory rate is 30. Saturation is 90% on room air. 70%, 90% on room air. On auscultation, bilateral coarse crepitation up to interscapular region. So interscapular means mid of the in between the scapulas. That is called as interscapular region. pH is 7.48. So pH is increased, right? PaO2 is reduced. PCO2 is also reduced. CO2 is also reduced. PaO2 is also reduced. Bicarbonate is somehow it is going to be near normal, because what is the normal value? 24 plus minus 2, right? So between 22 to 26 it lies down. So what is this? This is, yes, Mohammed, it is respiratory alkalosis, first of all. Respiratory alkalosis. Now, why the patient is going into respiratory alkalosis? Look over here. Respiratory, it is 30. So here patient is, might be hyper ventilating to take more breath over here, right? Patient is hyperventilating. Now, another thing, why it is in respiratory alkalosis, patient has landed and up to a pulmonary edema over here. Why pulmonary edema? I am saying that bilateral coarse crepitation up to interscapular region. Now, when the patient is in pulmonary edema, what sounds we hear? We hear crackles or crepitation. So this patient is in pulmonary edema. And when we have talked about, ARDS, that time I have spoken very clearly that these patients go into type 1 respiratory failure, or patient lands up into respiratory alkalosis. Why? Because the carbon dioxide gets dissolved in the carbon dioxide is a water soluble, and in pulmonary edema there is a lot of fluid which is present in the lungs. That carbon dioxide get dissolves over there. And secondly, some more, patient is hyperventilating, and when the patient is hyperventilating, what happens that time? The carbon dioxide washes out. That's why the carbon dioxide is on a lower side over here. Do remember this thing. Now let's discuss about the options. Are you going to go for an intubation? The people who were giving me the answer intubation, no, we are not going to do the intubation. Why we are not going to do the intubation? Bhai, patient is conscious, right? Heart rate normal hai, blood pressure normal hai. Just because his respiratory rate is 30, you are going to intubate. Some more, the strongest thing written over here, it is 10 by 15 GCS, beta 10 by 15. To go for intubation, what should be the minimum score? The minimum score is approximately 9 or less than 9. 9 or less than 9. 9 or equal to 9. This is the score where you have to go for an intubation. But here GCS is okay, 10 by 15. So you have to wait. If the GCS falls down, right? If the saturation falls down below 85%, right? Or patient goes into respiratory distress, then you can go for intubation. Okay. Second, people who were thinking that you are going to give IB normal saline, beta, look over here. Coarse crepitations means the patient is already in fluid overload. The patient is already in fluid overload, right? So are you going to go for a IV normal saline? Yes, you can give fluids as a maintenance therapy, but yes, aggressively IV normal saline at this state, you are not going to start IV normal saline. Why? Because if you start normal saline over here, what is going to happen? The pulmonary edema is going to get worsen over here, right? Right? Okay. So looking at all these features, right? Activated charcoal. I am not in favor of activated charcoal because looking all these symptoms, nausea, vomiting, tinnitus, right? Activated charcoal can be given over here, but choosing both of these options and looking at the picture, this case looks like this patient has a salicylate poisoning. Salicylate poisoning. The patient is having what, beta? Salicylate poisoning. Now this patient has landed up into pulmonary edema, and I know there is fluid overload. So what answer I am going to go? I am going to take out the extra amount of the fluid over here, and I am going to go for immediate hemodialysis. I am going to go for immediate hemodialysis. Right? Okay. I hope this was very interesting question. Vishnu Medico, you have given me a right answer, so I really appreciate your answer. Hanji, let's go to question number next. Bajendra, you are saying that better in the previous question, hemodialysis when there is renal insult. No, it is not like that. That you have to go hemodialysis for only renal insult. There are other indications of hemodialysis. No, fluid overload in pulmonary edema, you have to go for hemodialysis. Even you have to go for hemodialysis if there is any contraindication of giving the soda bicarbonate also, right? So fluid overload is also an indication of hemodialysis. Do remember this thing. I hope I made your point clear, Bajendra. Okay, time's up, guys. So they are asking what is the most likely diagnosis, and the options we have is paracetamol poisoning, quinine poisoning, methanol poisoning, and salicylate poisoning. Okay, so let's read the question. A 30-year-old female is brought to emergency with overdose of unknown substance. She took 10 hours ago. Now she complains of nausea, pain abdomen, tinnitus, hearing loss, and loss of vision. Very straightway. Tinnitus, hearing loss, loss of vision, nausea, examination, heart rate is 124, BP is on a lower side, ECG is showing sinus tachycardia with prolonged QT interval. What is the most likely cause? And you people have given me the right answer. Yes, this patient has gone into synchronism. What she has gone into? Synchronism. Synchronism. What is synchronism? This is a club of all the symptoms like nausea, vomiting, tinnitus, hearing loss, and loss of vision, which is caused by what, beta? It is caused by what? Yes, it is caused by quinine poisoning. Quinine poisoning, right? Or overdose. You can call it as overdose also, right? Some more. What are the others? Other what you call it as side effect of quinine overdose? The patient may land up into hypotension. So patient may land up into hypotension. Patient can land up into arrhythmias. Arrhythmias. Patient can have a prolonged QT interval, as it is written over here. Prolonged QT interval, right? Patient can go into here it is written over loss of vision. So patient can go into blindness, right? And all these symptoms are reversible once this quinine is withdrawn, right? And if they ask you about the treatment is with activated charcoal. Treatment is with activated charcoal, right? And this activated charcoal, it helps in quinine clearance. Activated charcoal. So do remember this thing. Beta, they are asking the first line treatment. Vasista Muhammad sir, I appreciate you have made the right diagnosis. They are asking, can you please be kind to tell me the answer now? Guys, they are asking the first line treatment. So time's up, guys. So what is the diagnosis over here? The diagnosis is scabies. What is the diagnosis, guys? Scabies is the diagnosis over here, right? Okay. Now you know that the scabies is the diagnosis. What is the treatment for scabies? Basically, two three important thing about scabies. Although you must have learned in dermatology, but this is also covered in medicine also. So scabies is caused by what? Sarcopitous scabia. We know this thing very well. And what kind of hypersensitivity there is? Delayed type of hypersensitivity, type 4 hypersensitivity. Now, what is the basic management over here? The basic management is this thing that first of all, you have to avoid the close contact from the person who is already suffering from the scabies. This is the important thing. And all the household contacts, they also need to go under treatment at the same time when that affected person is going thing. Third very important thing is that you have to wash all the clothes, bed sheets, towels, shirts, pants, everything very in a hygienic manner, or you can better go for a laundry or even for a dry cleaning of the things, right? Then my dear friend, talking about the drugs, right? So the first line drug over here is permethrin. How much? They may ask you the percentage also over here. So it is the first line therapy or the first line drug in the case of scabies is permethrin. The people who are giving me the answer ivermectin, yes, ivermectin may be used orally. Yes, it can be used. I'm not denying it this thing, but it is not the first line. So the first line is permethrin. It is given, and do remember this thing that it is applied all over the body from scalp to toes, everything very carefully, and it is left as such for at least approximately 12 hours. 12 hours, right? Okay. Then my dear friend, another drugs which can be used is melathon, and then we can also give benzoyl, benzonate, and lidocaine. That can be used, and but they are not the first line drugs, right? If they ask about the second line, then there is malathion. Malathion is another drug, 0.5%. 0.5% is the second line drug. This malathion is the second line. Permethrin is the first line. Yes, 5% I am talking. Jahid. Right? Permethrin. Time's up, guys. Time's up. Let's read the options. What is the likely cause of polyuria? UTI, olanzapine, lithium, psychogenic polydipsia. Let's read the question. A 40-year-old female known case of bipolar disorder. Very important clue. This is very important. Visit your clinic with increased urinary frequency and volume. Lab reports shows proteins present. Leukocytes are absent over here. Nitrates are also absent over here. What is the likely cause over here? So you have given me the right answer. Majority of you is giving me the right answer. It is lithium. So now can you please tell me why it is lithium? Why it is not? Why it is not option A? This is not the answer. Why it is not option A? Had it been a UTI, what would have been the options? That this leukocytes would have gone positive and the nitrates would have gone positive. Whereas in the option over here, these are negative over here, right? Some more the patient. Olanzapine, okay, we are just going to talk bipolar disorder, but this olanzapine is not going to cause What it is not going to cause? It is not going to cause polyuria or increased frequency of urine. So what we are left with? We are left with drug-induced diabetes insipidus. This patient is in diabetes insipidus. And what kind of diabetes insipidus? We know it is central diabetes insipidus, and another diabetes insipidus is called as nephrogenic diabetes insipidus. And this patient has particularly gone into what type of diabetes insipidus? It has gone into nephrogenic diabetes insipidus. What diabetes insipidus? It has gone into nephrogenic diabetes insipidus. So what are the causes of nephrogenic diabetes insipidus? Quickly revise. Now we are talking about particularly the drugs, because over here the patient is taking some drugs for the treatment of bipolar disorder, and the drugs which are mainly responsible are, yes guys, what is this? Lithium. One is lithium, right? The second one is the second one is Anji. The second one is demicocycline. What is happening? Demicocycline, right? Then we have other drugs like amphotericin, amphotericin, right? What are the other causes? So guys, here it is. I don't know. There is a printing mistake. Lithium. I'm writing over here. Among the drugs, these are some of the drugs. Other causes of a patient of nephrogenic diabetes insipidus may include like, what it may include like hypokalemia. I'm just going to talk about the important points. Hypokalemia, right? Hypercalcemia, hypokalemia and hypercalcemia, they are going to be the cause. Sarcoidosis, some renal diseases, right? Whereas if they ask you, I was talking about nephrogenic diabetes insipidus. Now, if they ask you about the central diabetes insipidus, what can be the causes of the central diabetes insipidus, guys? Can you please tell me what are the causes? First of all, it can be due to some idiopathic reasons. It can be due to some idiopathic reasons, right? Second, it can be due to pituitary surgery. Third is trauma, right? Then we have some thing which is called as uh, craniopharyngiomas, craniopharyngiomas, and it can be also familial also, right? Yeah, another cause is hypothalamic infarctions also. Hypothalamic infarction. So these are some of the causes of central diabetes insipidus, whereas all these causes are of nephrogenic diabetes insipidus. बेटा लिख दिया ना hypothalamic infarction, Sheehan syndrome, right? हाँ जी, next question. Time's up, guys. What is the likely cause of her symptoms? And the options we have is hypothyroidism, Graves' disease, orbital cellulitis, cavernous sinus, thrombosis. Okay, let's read this question. 36-year-old female visits her family physician with complaints of double vision. Very important, right? She says she was taking oral contraceptive pills. Now, this line is getting confused because I am getting two answers right now, and people are getting confused. On examination, she had mild bilateral proptosis and disconjugate eye movement. What is the likely cause of her symptoms? What is the likely cause of her symptoms? Now, look at the options carefully. Then I will go for this. Graves' disease is going to be the answer over here. Why Graves' disease is going to be the answer over here? Because in Graves' disease, what you are going to find, you are going to have bilateral proptosis. Bilateral proptosis. Sometimes it can also come with a unilateral proptosis, but majority of the time, Graves' disease is going to come with bilateral proptosis. And eye signs in Graves' diseases include like proptosis, one thing, lid retraction or lid lag, lid retraction, or patient can have a lid lag, right? Patient can have periorbital puffiness, periorbital. Guys, I really appreciate your patience. There was a technical issue. Somehow there was a power failure in my city. Um, okay, so this is today's last question, guys. So let's discuss this also. And I really appreciate for being over here in this time also. I hope now the thing is clear to all of you. Although this is going to be the last question. So a 30-year-old male patient visits you for a routine review. He is found to be hypertensive. Lab reports is, guys, understand this question very carefully. He is found to be hypertensive over here, right? Sodium is 138. Potassium is how much? It's on a lower side. The potassium is on a lower side. The potassium is on a lower side. Normal range of potassium is how much? 3.5 to 4.5, whereas it is 3. And serum creatinine is also 0.8. What is the most likely underlying cause over here? So guys, the underlying cause over here, it is Liddle syndrome over here. People who are giving, it is not renal tubular acidosis beta. It is a Liddle syndrome. What is Liddle syndrome? It is basically an autosomal dominant disorder inherited that mimics like an hypoaldosteronism. Now in hypoaldosteronism, there is also hypokalemia, right? But now, my dear friend, this Liddle syndrome, do remember, it is associated with hypertension and hypokalemia. It is associated with hypotension and hyperkalemia, right? Do remember this thing. So they may ask you some of the questions upon this thing, right? That what are the causes of hypokalemia and hypotension? So you have to be very careful in remembering these, MCQs, hypokalemia and hypotension. First is all Cushing's disease or Cushing syndrome, Cushing disease or Cushing syndrome. Then is cons, then is cons, then is 11 beta hydroxylase deficiency, hydroxylase deficiency. right? Now if on the other hand you find that there is a normal blood pressure, but